I see it now. We have about 8 people here. Rose, you're welcome. Nero, Jojaye Samson, Kapaya Tugulano, Fumbi Koka, Victoria Anolapo, Neju, Margaret SCU are all welcome to this year's Autism Awareness Program. Thank you for joining in. Thank you. Okay, so I think we can start.
Nkoya, we can't see you.
Start. Okay, you can't see me. Oh,
yes.
Okay,
can you face?
Can you see me now?
Yes, we can.
See me now?
Thank you.
Okay. Oh wow. I'm seeing myself in 3 places. I'm seeing myself as Mrs. Okerafor, Dr. Boye, but I'm sure you can all see yourselves. So
yeah, we're good on this side. I'm good from here.
Okay, Dr. Boye, are you okay?
I'm okay, thank you. I can see you, I can hear you.
Dr. Boye?
Yes, I can see you and I can hear you.
Okay, that's good. So it's all right. I can hear you too. Thank you. Thank you very much. All right. So without wasting any time, we'll just start off immediately. I would like to say welcome again to this year's Autism Awareness Program. Thank you all for agreeing to do this on such short notice. We really appreciate it because we know that you all have it. On behalf of the organizers of this event, of the panelists, thank you so much. I'll be starting up by reading the of the panelists we have for today. So if I do not read your profile, it's probably because you're not speaking today. And so tomorrow your profile will be read. So I'll start with Mrs. Patricia Oranye. Mrs. Patricia Oranye is a certified speech and language pathologist and a seasoned special educator. She believes that her clients are priority. She works with clients of all ages and improves their quality of life. She attended Nigeria's premier university, the University of Ibadan, and proceeded her master's degree as a Ford Foundation International at Austin, USA, United States of America. In her professional career, Patricia had the opportunity to work with a variety of populations with different disorders such as autism, speech and language delay, articulation and fluency, traumatic delays. She gained a wealth of experience working as a speech and language pathologist at a variety of settings and gained a lot of knowledge in intervention. Presently, she's the principal consultant at Easy Speech by Shepherd, working closely with families, schools, hospitals, and rehabilitation facilities. She's a staunch advocate of inclusive education. In her spare time, she volunteers to train teachers on the best ways to work with children with special needs in the classroom. Please, I'd like us to put our hands together, or better yet, put your clap emojis for Mrs. Patricia Oranye. I'd like to see that in the comment section. Let's put hands together, all the clap emojis for Mrs. Patricia Oranye. Thank you so much for sparing your time, Mrs. Oranye. Thank you very much. Straight away, we'll go to Dr. Gbemisola Boyede. Now this is, thank you so much. Dr. Gbemisola Boyede is a neurodevelopmental pediatrician and founder as well as CEO of Ask the Pediatricians Foundation. She started Ask the Pediatricians Foundation, a registered non-governmental organization in Nigeria, first as a Facebook group in July 2015, out of her passion as a pediatrician to reduce unnecessary and preventable deaths of children, which are often due to ignorance in Nigeria and sub-Saharan Africa. Dr. Boyede was born and bred in Lagos, Nigeria. She did her undergraduate medical training at the University of Lagos. Dr. Boyede is a fellow of the West African College of Physicians, Faculty of Pediatrics. She's also a subspecialty fellow certificate in developmental pediatrics from the College of Pediatricians of the Colleges of Medicine of South Africa, and a Master of Philosophy MPhil degree in developmental pediatrics. Wow. With distinction in thesis. Wow. I hope you all know what the caliber of panelists you have here. So if you know anybody who hasn't logged in, please start buzzing them right now. I'll go on with distinction in thesis from the University of Cape Town, South Africa. Dr. Boyede is actively involved in academics and clinical research and has published papers in local and international journals. Dr. Gbemisola Boyede has organized training for general and trainee pediatricians in basic developmental and autism assessment. She currently works as a community pediatrician with the NHS UK. She has a vast experience in assessment, diagnosis, and management of children on the autism spectrum. Aside from her job as a neurodevelopmental pediatrician, Dr. Gbemisola Boyede volunteers her expertise as a pediatrician in promoting child health intelligence for parents via her online Ask the Pediatricians Facebook group and website, and through free community medical outreaches to children living in indigent communities. Wow. Dr. Boyede writes and speaks regularly on healthcare issues on national dailies, radio, and TV programs. Dr. Gbemisola Boyede's work on the Ask the Pediatricians Foundation has been recognized and featured in many local and international media, including the BBC. Dr. Gbemisola Boyede is a recipient of many national, regional, and international recognitions, fellowships, and grant awards, such as Facebook Community Leadership Fellowship Program and grants of $50,000 for community work by Facebook International in 2018 and SCORE World Forum Fellowship for Changemakers in 2019. Her foundation, Ask the Pediatricians Foundation, is also a two-time recipient of the Social Media for Social Good Africa Awards in bracket health category for 2019 and 2020. Ladies and gentlemen, please put your hands together. Put your hands together for Dr. Gbemisola Boyede. And in the midst of all of the things she has to do, she took time to be here today. Like I said earlier, if you know somebody, it's not too late. We haven't started hearing the panelists yet. If you know anyone that should be here, start buzzing them now. If you have to meet these people outside of here, you know what it means. When you see this kind of CV, your heart will first of all do backflips. So please put your hands together for Dr. Boyede. Thank you so much, Dr. Boyede, for honoring our invite. Thank you.
Thank you for having me.
It's a pleasure. Next on my list is Mrs. Mabel Okerafo. Let me take a deep breath before I read it. Mrs. Mabel Okerafo graduated from the prestigious Obafemi Awolowo University with a bachelor's degree in psychology and went on to complete a master's in developmental psychology from the University of Lagos at Koka. Mabel is a trained early interventionist with experience in supporting families of children with or at risk of developmental delay and disability. She's the clinical director at Nuture Child Development Clinic, Nigeria's pioneer private pediatric psychology practice. Mabel is a licensed member of the Lagos State chapter of the Nigerian Psychological Association, the Nigerian Association of Developmental Psychologists, and an associate professional member of the Society for Child and Adolescent Psychology, SCCAP Division 53 of the American Psychological Association. In addition to being a Pearson Qualified Test User Level C, Mabel has received training with the Arizona chapter of the American Academy of Pediatricians on the use and interpretation of parents' own assessment screening tool for birth, from children ages 0 to 8 years of age. That's from birth to 8 years of age. Mabel is a HANEN, in bracket, Canadian licensed early communication professional, a trained JASPA Florida practitioner for children with autism spectrum disorders, with additional training from the Florida Institute of Technology in verbal behavior therapy, and a Ruby parent coach. Our areas of expertise include developmental screenings, assessment, psychological assessments for children to determine learning profiles and develop treatment plans, parents coaching for children with disruptive behavior patterns, and school-wide special education policy development, consultation and supervising multidisciplinary intervention teams. Please, let's put our hands together for Mrs. Mabel Okerafor. She's also the convener of this program. We have to say a big thank you for staying true to the vision. Thank you for putting this together, for being in families. Please, let's put our hands together.
Thank you for having me, Nkoye.
And you're welcome. Thank you so much. And then my next panelist, Mr. Olusegun Samuel Fakorede. Olusegun Samuel Fakorede is an occupational therapist who had his training in occupational therapy at the Federal Neuropsychiatry Hospital, Oshodi, Lagos, and his bachelor's in occupational therapy from the Manipal University, India. Mr. Olusegun Samuel is passionate about children and adolescents with special needs over 10 years and has over 10 years experience in the field of developmental disabilities as an occupational therapist with the NHS UK. Please, let's put our hands together for Mr. Fakorede. It's a pleasure to have you here because I know you are also busy. Please, let's hear it for Mr. Fakorede. Thank you so much. Thank you for being here. Okay, Mr. Fakorede, I hope you can hear us.
Yeah, I can hear you. Thank you. Thank you for having me.
Okay. Right, that's good. All right, immediately we're going to just move straight to program. All right, so we know that our theme for this this year's program is early detection, diagnosis, emerging trends and opportunities for children with developmental delays. Or basically, I want us to stay with the early detection, diagnosis, and emerging trends and opportunities. So that's what is forming the base of every question. Will be, I like to use the word throwing at the panelists, but I'm not in any manner of phase. They are very capable, and I'm here sitting and praying that the time frame we put for this meeting will be okay. We said 5 to 7 for the caliber of women and gentlemen that is on this panel. I hope we will not exceed the time. All right. So Dr. Boyede, I'll be starting with you. Okay, so my first question is this, and it is for Dr. Boyede. My question is, what are the early signs of autism in children? That is, what are the red flags parents and clinicians should look out for? I want you to please note the fact that we said parents and clinicians. Okay, so please, what are they?
Okay, thank you so much. And let me start by saying My thanks to Nuture CDC for inviting me to this program. It's a pleasure for me to be here. Any opportunity to advocate and to talk about child development is something I welcome. And also to say happy World Autism Awareness Day to everyone. Thank you so much for joining us. Talking about autism or autism spectrum disorder. Let's just start by saying that autism is a developmental disorder that is common and that affects children and even adults, and it is characterized by difficulties with social skills and the presence of what we call repetitive or restrictive pattern of behavior. So breaking down all those grammar is just for me to be able to say what are the things we look out for in autism at the early signs of autism spectrum disorder for parents especially, and then I will move on to the clinicians. So there are two major things that characterize autism. The first one is social skills difficulties, and then the second is the presence of those repetitive or unusual kind of behavior. So those are the two so those are the things parents should look out for. So what are the social skills we expect in children? Usually by the 6 weeks, children should have what we call social smile. So when you smile to children, even when they are not talking, they smile back at you. Then sometimes by the time they're about 6 months to 9 months, they start to babble. It's like you're having a conversation with them, even though there are no clear words. But it's as if the child is talking to you and you're talking back to them, but we call it conversational babbling. So if you see a child who is not smiling, who is also not having that conversational babbling by that around 6 to 9 months, then by 1 year, most children, our speech therapists ahead, at least they should have one word. And then maybe by 2 years, they should begin to put 2 words together. So sometimes there's also no speech at all, no words. And usually for children who cannot even have, who don't have words, they compensate by what we call non-verbal communication. So the child may point, and all that. So if a child is not talking by 2 years and it's also not giving, like pointing to show you what they want, then we worry. Those are signs that parents should be looking out for, and so that may tell them that there may be something going on here. Then there may also not be presence of other things, unusual behavior. For example, some children will be flapping their hands, some will tiptoe when walking, some children will do some things over and over again, like they may be lining up their toys, or some children will be turning the wheels of the cars they're playing with. They may not be interested in playing with other children, those kind of things. So when we see all those kind of lack of interaction, lack of social interaction, and then presence of repetitive behavior or unusual behavior, like some children will look at you through the corner of their eyes, no eye contact and all that, then parents should know that there's something not quite right here. And so at that time, it's better to seek for help from the professionals. And of course, the professionals, it's very important for professionals that we know what are the signs to look out for. And one of the things I tend from my experience in Nigeria is parents actually are better at picking up the signs, and then they go to the doctor, because parents are very good. They may not know what is right, what is appropriate, but they know how to compare children with other children. So all of them are looking at, these are your cousins, these are children that were born at the same time, my children's friends are born at this time, they're already talking, they're already doing this, they're already doing that. Why is my own child not doing that? So parents always know that there's something odd or unusual about my own child, because it's not doing what the other children in the nursery school or in the Sunday school or at home are doing. When the cousins come together, they always notice that. Then they come to us as the professionals, doctors, nurses, all our health professionals. And one thing that health professionals normally do is just reassure parents and tell them there's nothing wrong, the child is just being slow, it's just being delayed. I find out that is very, that's a major challenge for us in Nigeria especially. So professionals should please know that when children are not talking by 2 years, don't dismiss parents, don't reassure them without really making sure the child has a proper assessment. Because one thing with autism is that it's a spectrum. So not all children will look similar. And I noticed that professionals are always looking for a classical autistic presentation, like even parents can make that diagnosis. Most children are not going to come that way. And the child may be talking, and let me quickly backtrack and saying that all those signs I've mentioned does not always mean that a child has autism. So a child may not have eye contact, does not necessarily mean the child will have autism diagnosis. So sometimes when it's professional says that a child is not talking but is making eye contact, and they think, oh, it can never be autism. Again, the fact that a child does not have eye contact means the child will have autism. It also does not mean that a child who has eye contact will not have autism diagnosis. So autism is all those pictures may be different. So it's very important for us to also pick up one or two signs, and there are a lot of screening signs. I'm sure we're going to talk about that. Maybe my other colleagues, panelists will talk about that. Once a parent comes to us, we should screen them. We should screen them for the autism and then take the right approach. So it is not just enough for you to go by your own feeling like, okay, oh, he has eye contact, then it does not autism. No, you should do a proper screening, looking for all those social skills, all those repetitive behavior, and then get the child seen by the appropriate professionals who can do the further assessment. Thank you.
Very much, Dr. Boyede. So I was going to move on to another person, but you said you touched on some things which has led me to my second question, and so that we don't drop this tempo. I was just my next question to you is this: how then is autism diagnosed? And right now, what I am asking is, what is the process that should be followed when it comes to the diagnosis of autism, if there is a process?
Well, ideally there should be, but not many people are aware of that. But continue from where I stopped. When parents pick up signs, when professionals pick up signs, there are lots of signs that we all pick up. I mean, one of the commonest is the fact that the child may not be talking, the child is not interacting, the child is not playing appropriately with toys. So children at that age need to pretend to play. So they will pick a phone and pretend to call you on the phone, and then all that. When they see family members come around, they are very happy, excited, they run to grab them, give them hugs. Some of the children on the spectrum will not do all that. They just want to be on their own. So parents always say things like they're in their own world. They just want to do certain things over and over again. So when you begin to see all those signs, you should get access to, ideally you should see a pediatrician. In some other places, maybe they see their GP, but you just first see your first line professional, usually the pediatrician. And it is not every pediatrician that can assess a child for autism. So autism assessment is a multidisciplinary assessment. In other words, it's an assessment that involves multiple professionals, and the professional that tends to do it include our developmental pediatrician, our speech therapists, psychologists, and then occupational therapists. So we tend to do it together in some places, but in some places, maybe sometimes if they don't have that multidisciplinary setting, then the developmental pediatrician or the the children's psychologist can also do the assessment. So the process is for the child to see the pediatrician. Ideally, the pediatrician can do a further screening and looking for whether there are enough signs for her to do an autism assessment. So if there are many screening, I actually recommend parents do the M-chart. The M-chart is actually for, it's called Modified Checklist for Autism in Toddlers. That's the full meaning of M-chart. It's available online. It's very easy. There are websites like Autism Speaks, as it's on the website. So you can actually fill it online and it will give you back your results immediately. So if you just score less than 2, we are not worried, because that is, we call it low score or low risk. We will not want to bother. But if the child score more between 3 and 7, moderate risk, usually for those kind of children, they need to do it again. We call it the follow-up kind of M-child. If the child score more than 8, that is high risk already. And that means the child needs to see a pediatrician for autism assessment. And actually, when the child is now referred for the autism assessment, because autism there are what we call diagnostic criteria. So for example, autism is not like malaria. It's not like which other, like other infection that maybe you do a blood test and it gives you a result, then you see malaria parasite and you say you have malaria. No, autism is a clinical diagnosis. So it has to be made by a clinician, and there are criteria we need to tick. So we need to see, so it's not enough, like I was saying, each of those features I mentioned alone does not give a child autism diagnosis. The child needs to tick or certain number of criteria before you can say, yes, this child meets the diagnostic criteria. Currently, we use the DSM-5. Some people use ICD-11. Those are the criteria. So on those criteria, for example, let me just stick with DSM-5. We have got the A, the B, and the CDE. So, but usually the A and the B are the major ones. So the child needs to tick 3 criteria under A and needs to tick 2 out of 4 on the B, and then C and D can help you further along the line, but they are not really like essential for you to make a diagnosis. So what the pediatricians and all the other professionals basically who are assessing for autism does is to get information from parents, to see, we call it like parental interview, to get those information, whether the child actually meets all those criteria. And then we're also observing. So we need to also observe whether we can see the child doing some of those, those criteria, the child is actually ticking them. I will say come to them later. And autism has to be pervasive. So in other words, those criteria must be present, not only when the child is at home with the parents, they must also be present when the child is in school. They must be present when the child is in the clinic with the pediatrician. So that is why other professionals need to observe the child to make sure that all those criteria are present before we can now say, yes, based on the DSM-5 criteria, this child meets the diagnostic criteria for autism spectrum disorder. So what are the major criteria? We have the A. So the A has to be talk about deficit in social communication, social interaction. So you have the A1, the A2, the A3, but basically they're all about social interaction. And it's not about verbal. So it's also about non-verbal communication. Is the child having social interaction? Is the child developing friendship or relationship that are appropriate for that child's age and all of that? So those are all the A parts. Then the B part is what we call, we're looking for what we call stereotype behavior in terms of the speech. So the child, some children have what we call echolalia, they repeat other people's words. Instead of saying their own words, they just repeat other words. Or is it mutual stereotype, like the child is flapping, is rocking, there's one video I saw online, very, very lovely, showing all those features, and it's available for parents to actually watch. So you see what we are talking about, stereotype behavior. Or some children have facial mannerism, they do their finger, funny, so we call it hand mannerism. So we're looking for that. Or are there what we call, like the child has what we call rituals. So some children, they have to count everything they do. They have to, maybe some children before they go and do something, like there's one child I was assessing, anytime he pick up a toy, he must bang it on the floor. Then before he puts it there, he must always do that. You will never stop doing that. There are some children have what we call excessive attachment to certain things. So you see them, they must always have maybe one particular toy, they must come to the clinic, or they will only take only one particular way, or they must eat only one particular food. They only eat from McDonald's, and it has to be that McDonald's brand, no other brand. So if when children have those ritualistic kind of restricted kind of behavior, or they have what we call sensory sensitivity. So some children are always like, even if it is boiling hot, they must still have their jacket on, or some children have very low, very high pain threshold, or it is food. Some children cannot eat certain food. Some children will only eat bland, food that's either they can only eat with their finger, they will never eat anything that has sauce or anything like that, or it smells. Some children have sound, they cover their ears and all that. For the B part, you only need 2 out of 4. You don't need to have everything. So if a child is seeking A and seeking B, and this must be present before the child is like 5 years old, it's a developmental diagnosis. In other words, it must have been present in early childhood. So that is the C, and of course, it is affecting the child in terms of school and others, home and all that. So it is not just the child has this thing, but it's actually impacting on the child. Okay, so vitamin. So when the child has all those, that is how we make.
Dr. Boye, you're already answering some questions we're going to ask you later.
So okay, sorry, I'm just trying to talk about how we do the autism assessment. Yes. Yeah, so that, okay, let me just stop there then. So that is just how we do it. So then the pediatrician can now give. And
in this field, it's not, some questions are not just straight yes. So, but thank you so much. It's just, honestly, some people have had free consultations with this answer you've given already. At this point, because you've mentioned something about verbal and all of that, I will have to go to Mrs. Oranye. And my next question is for Mrs. Oranye, the speech pathologist. Ms. Oranye, I need to be sure you can hear me first. Can you hear me? Mrs. Oranyi? Is she still with us? Can everybody hear me?
Yes, we can hear you. Mr. Ryan, your mic is muted.
Dr. Ryan, you're muted. That's why we can't hear you. Dr. Ryan, Mr. Ryan, you're muted. You need to unmute yourself. Otherwise, you'll be talking and we'll not be hearing you. Just tap on the microphone icon. It will unmute.
Okay. Yes,
Tap on
yes.
it.
Can you hear me now?
All right. Oh, yes, I can hear you. Okay, so
Okay.
now, my question to you is this. As a speech therapist, please shed some more light on some of those early signs parents and educators should look out for when autism is suspected in a child. So you're coming from the perspective of a speech pathologist.
Okay. And at the same time, the key word there is the parents checking any signs of autism when a child is suspected for autism. Okay. Now I'm going to be taking the signs based on personal experiences, and then from the ASHA, the American Speech Language and Hearing Association website. Okay, because I also like to back up what I say with what the association's guidelines are for looking out for early signs of autism in children that are suspected to have ASD. There are quite a number of them, but the first things you hear when a child is suspected to have autism is lack of communication, repetitive behavior, and then no language. But it still goes a lot further than that, most especially when you go back all the way from the time a child is 6 months. You could start suspecting that this child, something is really not quite right. Okay, and then what are some of those signs? The first one is differences in eye contact. Okay, a child that is suspected to have autism would not look at you, would not look at the parents, would not even maintain eye contact. Even when it's there, it's fleeting. By fleeting, I mean they just look at you and look away. You're talking to the child, but he's not actually eyeballing you. He's not looking at you. So when that happens, it's the red flag that parents can look at. And then eye contact usually develops between 6 and 9 months. Children start looking at you when you talk to them, you see them actually paying rapt attention to what it is you're saying. Now, the second one is joint attention. Now, children that are suspected to have ASD, autism spectrum disorder, would not engage you in terms of play, or they will not engage you when you're actually with them, all right? For example, you can be talking with them and then the parent says, oh, look. The child does not follow your points, does not jointly attend, is not interested in seeing what it is you're showing him or her, all right? So it appears they're not even listening to you, all right? So they don't jointly attend. And the same thing too, they don't even, when you're playing with them too, they're not, it appears they're not interested, okay? So there are differences in joint attention, with children that are suspected to have autism. Now, there is an inconsistency in them answering to their names. Inconsistencies, or in some cases, no, they don't have the ability to respond when they're called. All right, usually when children are about between 4 to 6 months, when you call their names, or maybe much later than that, probably by the time they're about a year old, when you call their name, the first thing is the turn and the look. Now, for children on the spectrum that are suspected to have autism, as early as 12 months, if a child is not responding to their names, that's also a red flag that parents should, take note of. Now, there's also the problem with pointing, all right? The pointing skill, pointing to show. Now, pointing skill develops in children from about 9 months, okay? You see a child, maybe you're walking on the road with them, the parents are walking on the road and they see a dog or a cat or something strange, and you just see them pointing, all right? That's also a form of joint attention. They tell you, oh, mom, no what's yet, but they're pointing. Oh, what they're telling mom, oh, mom, see, that thing is, I don't know what it is. Could you tell me? All right, so they're not pointing to show you. And then they're not also, when they see something new, they don't really, get to, they're not interested in sharing that attention with someone. So that's a red flag. So by 9 months, parents should also start looking at, oh, is my child doing this? Now, there are milestones that parents need to actually look at for early signs of autism. Well-trusted websites like the ASHA website that I've mentioned. The Center for Disease Control US also has websites where parents can actually keep track, especially new parents that just have newborn babies, and they really want to follow through with checking out for these early signs for autism. Now, another one too that another early sign that parents need to take note of is their inability to imitate. Imitating verbal and gross motor actions. By verbal skills, I could tell a child, for example, say dog. A neurotypical, that's a typically developing child, will definitely immediately say that. But a child on the spectrum, you would not. And parents often say, oh, I'm not sure this child is hearing me. I'm not sure he's hearing me. I tell him to say things, he doesn't. But it's just the way their brains are wired. Children on the spectrum have a different neurological difference. All right, so their brain is wired so differently that it affects, even visual imitation skills. So they cannot visually imitate and they cannot verbally imitate. So that's also an early sign that parents also need to take note of. And imitation, such as waving, by 12 months, a child should be able to wave, bye-bye. When you tell the child, oh, say bye, the child just does this, does that. But children on the spectrum, as early as 12 months, parents should look out for that. If a child is not waving and is not imitating, it's also an early sign that the child could also be on the spectrum. All right. Of course, there is also the nonverbal, the lack of expressive language. A child on the spectrum, would not, move on from the babbling stage. Some of them will keep babbling, but you hear very limited sounds. For example, the consonant sounds. Some of them can't move past that. Okay, babbling sounds are sounds that, are naturally occurring in children, all right, as they develop. But for children on the spectrum, they don't go past that. And then another thing too that I want to mention is now there are different, just like Dr. Aboyede said, there are different children on the autism spectrum. For some, you could already see them having, those signs like being able to imitate or being able to have a few words, but they can't go past it. But I'm not talking about children that are non-verbal, that are not even saying anything. They cannot go past beyond the babbling stage. All right. So it's quite difficult that parents will think, oh, I don't think this boy is hearing me. I think something is wrong. He's not talking. A 12-month-old, my 12-month-old neighbor is starting to say, Mama, Baba, bye, Dad, but there's nothing. So you see a lot of limited, very limited or even non-existent expressive and even receptive. I will explain what expressive and receptive language skills are. Expressive is the child is not able to talk.
No. I think we need to pause.
All right. So that is basically some of the early signs that parents need
Mrs.
to look
Orion,
out
we need
for.
to pause you there. Okay. Now,
okay.
Thank you very much, Mrs. Orion.
Yes.
One of the things about this program, when I saw the list, you remember I said it that I don't know if 2 hours we caught it. So it's almost 6 already, and we haven't even touched 2 of the other panelists, and we still have questions. So this is what I'm going to do. So for each question, please, to my dear panelists, can we try to answer within 2 to 3 minutes? If it looks like we didn't do justice to the question, we can decide to push more. We'll work around it, but so that we'll keep our word when we say 5 to 7, and that's the way it can happen. But Mrs. Orion, I'm with you. My next question to you, based on what you said looking at some of the things you mentioned, now I'm going to ask this. Oftentimes, parents and non-speech clinicians tend to confuse speech delay autism. First question here is, are they the same? Secondly, if they're from a non-clinician, so it's almost like a 3-in-1 question. Delay and autism, one, are they the same? So if they are the same, what should one look out for? Thank you.
Okay. All right. So like you said, I have 2 minutes, so I have to be very brief. All right. Now, speech delay is also the same thing as late language emergence. Okay. Now, quickly go through what speech delay is. A speech delay is a child that does not have, it has difficulties putting words together by the time they're 12 months. Okay, in the absence of any speech and language problems, maybe there are no conditions, nothing else is going on. But this child has words, maybe about 50 words, but stringing those words into sentences becomes an issue. Now, that is different from a child with autism. Children with autism that are suspected with autism, do not have words. And even some of them that have words also, might have challenges stringing words together, okay? So that is a major difference. So speech delay, not putting sentences, not putting words together to form sentences. Words are just 50, all right? And then there is an absence of any conditions, that there's nothing else going on with the child. There is no autism, there is no Down syndrome, all right? And then with speech delay, children with speech delay, the major difference is a child with speech delay has no problems with using gestures, all right? They use gestures as their main module of communication, all right? They point, they wave, all right? They nod their head, they shake their head, no. Problems with expressive communication, becomes a little bit of an issue, but they are very good with receptive language. So that is another difference between a child that has a speech delay and a child that has autism. So there is just issue with expressive, being able to speak, but they can understand, which is receptive. So that is one clear difference between speech delay and then autism. Now, also for some children with speech delay, they have difficulties with having conversations, all right? Like I said, they can't string sentences together, and then it's also different from a child on the spectrum that they don't have words and they cannot also make sentences. So it's kind of overlapping, all right? In autism, they have speech delay, but there are also differences, in terms of, like I said, one group using gestures, while the other one, there's an absence of gestures. So I can just stop there for now. I hope I'm clear. So that I don't, there's so much to say. There's so much to say, but
yes.
Time is limited.
Yes, and one thing with this field of ours is that it's very easy to start a lecture on it, because it's just like you said, there's so much to say, so we'll just have to work within a time frame. Before we move on to the other 2 panelists, please let's remember that this program is a 2-day program. It is a 2-day program, which means we also have another program tomorrow at the same time, 5 to 7 p.m. with a different set of panelists. So you hear Mrs. Orion. My next question will be going to Mr. Fakore. So Mr. Fakore, can you hear me before I go on? I want to be sure you can hear me.
Yes, I can hear you. Yes,
but I think at this point, okay. So since I've already called on you, we're going to take your question. We're going to send a question to you, and then after you will have the admin put up the poll. So admin, after Mr. Fakorede's answer, you can then put up the polls. Mr. Fakorede, my question to you is this: occupational therapist, what are those signs we should look out for with regards to autism spectrum disorders? Coming from the part of an occupational therapist, what are those things that I'm noticing that you say that when you see, you'll be like, okay, this I'm suspecting. So let's hear it.
All right. Thank you, everyone. Thank you for having me. So, I promise everything I'll be saying to you today is evidence-based, and then what I've seen from the year of experience. Okay, so what you're looking at as an occupational therapist is not different from what the doctor has seen, and then from the diagnostic criteria. Okay, so now as an occupational therapist, how are those things, how are those signs, how are those things that the doctors have seen? How is it affecting the patient function in terms of home and in school? How is it affecting the patient participation? Okay, so if you look at it, affecting the child's communication, social interaction, restricted and repetitive pattern of behavior or activity or interest. Research has shown in the DSM-5 has added something that is called difference in sensory responses. Difference in sensory responses. You can rule out sensory responses when you're diagnosing a child with autism. It must be present. Okay, so the DSM-5 has said that, okay, this activity and then repetitive behavior might be due to what? Hyper and hypo reactivity to the sensory input. So we need to know that most of the children with autism spectrum disorder, the important thing about them is that the difficulty you see in them is how to process that information. When you want to look at them as a parent, you want to look at the sense organ. You want to look at how your child is responding in terms of all the sense organ, your hearing, your sight, your mouth organ, the smell, the movement. You know, you want to look at all this sense organ. How is it affecting it? So now a child might be very hyper, a child might be hypo. Okay, so they might do something, they might respond differently to pain and temperature, they might respond differently to sound, texture, excessively smelling something. What does it mean for a child to be hyper? A child might be just wanting, like, hypersensitive, like seeking for something. Hyper, hyper to touch. The child is avoiding it. The child is hypersensitive to touch. Let's take that one for example. The child is hypersensitive to touch. I don't want this. I don't want it to touch me. The child is hypersensitive to sound. The sound is too much for me, for my brain to actually comprehend. I don't understand what you're saying. It's hurting me in the brain. Or you want to look at how the child is hyposensitive to it. So now the child is hyposensitive to it in the sense that the child cannot even understand. The child wants more of it. The child wants you to say it again, over and again. Go and bring me this. The child cannot even process the whole information. A child that is hypersensitive will quickly go and run and go because the child is a bit of inattentive or wants to run and do the thing in the times of auditory processing. That's hearing processing. So you also want to look at all the sense organ. How is it affected? You know, the speech and language pathologist has said a lot. The doctor has said a lot. So you want to look at this together. How are these signs affecting my child's function at home? I'm talking to my child. This is a home environment. As a parent, how is it affecting your child response? I call my child is not responding. My child is not eating food. My child is selective. My child is not allowing me to cut his hair. Why? Why is this happening? Or my child is just running around. Oh, what's going on? You want to start asking yourself questions, or to the professionals or to the practitioner. Why is this child not sitting in one place in class? Why is the child always wanting to stay with one object or wanting a particular color when you want to teach colors? And then the child is making work difficult for you. You get what I mean? So you want to look at these signs, and then this is the repetitive pattern of behavior you want to see in them. And then this is then linked to their sensory responses. You know, they process it differently. And then when you look at children, it might be very mild in some, it might be very severe in some, and then it might be moderate in some, the way they process this information. So at times it might be very confusing. And then when this is in them, together with other diagnostic criteria, it then begins to affect their day-to-day activity. So basically, these are the things you're going to look into in addition to other communication, social interaction, like it affects their play, because as a child, the major occupation of a child is play. It affects their play, it affects their involvement with you yourself. Like the speech and language said, the child is not talking to you, not smiling to you. You know something is wrong. The child is not responding to sound. The child is fixating on one particular light, or the child enjoys bright light. The child wants more light to be able to register that light. Or the child does not even understand. You know, so these are the things you begin to look into. It should also, if you're diagnosing a child with autism, you have to look into the sensory aspect of it. Thank you.
Okay, thank you. That was direct. And he worked his best to stay within the time frame. Thank you so much. Mr. Fakorede, before we come back, I'll ask admin to please let out the post now so that the audience can get involved. Okay, admin, over to you. So we're going to take a minute or two off so admin can open up the post so the audience can see and participate. Thank you.
The poll is presently being administered, and just a question. I can see 22% up, 23, 26, 28, 29, 30%. So once it reaches 100%, then I will notify you to continue. People are presently answering the questions. So I have 43%.
Yes, I can see it. I can see it. I can see it on my screen, so I can see it.
I've been trying to get your attention, so I didn't get anything. That's why I'm speaking. So I'll just go silent again. A lot of questions there. You might need to let the people know that you are taking note of it.
Okay. Okay, so for our first question, we asked, early diagnosis doesn't make it any easier for parents to deal with. 33% said true, while 68% said false. Okay, so the question was, early diagnosis doesn't make it any easier for parents to deal with. Now, 31%, we've had more participants. 31% said true, that early diagnosis doesn't have any, it doesn't make any difference. However, 67%, thankfully, said it is false, meaning early diagnosis does make a difference. While I'm tempted to say who is right or who is wrong, I will just I'll just pass the baton to my next panelist, which means I will have to come back to Mr. Fakorede. Okay, so at this point, we need to get Mrs. Okerafor involved. I'm not happy with the fact that being a developmental psychologist myself is worrisome. So at this point, admin, I think we can have the polls down, because it seems to be increasing. It's now on 33%. Wow. We're having more people say it is true, and 67% are saying it is false. Thankfully, we still have 67%. So, Mrs. Okerafor, my next question is to you. So we hear that children can be identified as early as 18 to 24 months. What are those behavioral markers parents are to look out for? Okay, and then, okay, so answer this, and then I'll throw the next question. Let me break it so that people can get you can just answer it as it is. Okay, so Ms. Okerafor, if you can hear me, please, you have the floor.
Thank you.
You can take down.
Can you hear me? Can you hear me?
Loud and clear, yes, it's loud and clear.
Okay, I think
we can hear you loud and clear.
Yeah, thank you very much. I think to a large extent, the previous speakers have done justice to the identification of autism in children, basically starting from the diagnostic criteria. I particularly like the fact that we had that extensive discourse in terms of how to get it right, in terms of checking all the required criteria on the DSM-5, because that's where the whole issue usually would start from, right? In terms of missing or a child having a wrong diagnosis. So it's been fabulous so far, and I want to thank all the other speakers for such fantastic foundations having been built. So what are those behavioral markers? I, in particular, work with very young children, and like Mrs. Oronye rightly said, sometimes it can be very, it can seem evasive, really, when you have the very young ones. But what are the things that over time research has shown that are valid, that we can look out for when you see an 18 months old, a 24 months old, apart from the very obvious one that parents would see? So sometimes parents come, sometimes they tell you, okay, so their speech is present, right? But it's atypical. Okay, so they tell you, my child is talking, but I want my child to be conversational. Conversational is usually the word they use, means there's no reciprocal communication going on with the child. So you have a child that can, so the child is watching the Coco Melons, the Baby Shark, and the child can actually recite all of these nursery rhymes, but this same child would see fish or a model of a shark, and the child is not able to say, okay, this is a shark, or I want my toy shark, and all of that. So that's one of the ways you would identify that this child possibly could be presenting with an autism spectrum disorder. The other thing we also tend to find out in terms of those markers is imitation, right? Imitation is very critical skill when it comes to all forms of learning. Basically, we learn by observing what's going on in our environment, and also trying to imitate the behaviors and the language of other people. So when we find a child that has difficulty imitating or has an atypical kind of imitation, in which case for children on the spectrum, so the child could imitate vocally, but the child is imitating atypically in terms of echolalic presentations. So what's your name? And the child goes, what's your name? Rather than responding. So we'll find that imitational skills are usually problematic for children on the autism spectrum. So apart from that, you also have the eye contact, no response to name. And then you also have the basics of joint attention. I always tell parents when they come in that even before your child says the first words, Dr. Bayo did mention that at 6 months, at 9 months, when you have the social smile, you have what we call engagements. Okay, so the child is able to stay socially connected to you. There's eye contact for social sharing, okay, for very young children from that point on. So you want to be able to see the child engage. And if that child is able to engage, it means the child is able to do some back and forth communication, nonverbal communication with you, either using their eyes or using their gestures and all of that. So when we don't see that, okay, we know that there's something that's amiss here. Particularly, we look out for what we call a 3-point gaze in toddlers, right? So you're sitting with your little child, and your child is playing just very close to you, and a stranger walks into the room. A typically developing child would look at the stranger, like, who's this person? And look at the parent, or possibly look at what they're doing and all of that. You would see that point from person to object and back to person. You usually would see the child doing that. When the stranger comes in, the child will do that social referencing. When the child is playing with an object and they happen to come upon a new discovery, maybe the toy responds in a different way they are used to, or they feel they've achieved something that mommy or daddy has been trying to teach them, and they just finally have been able to do it, you would find the occurrence of a 3-point gaze in a typically developing child. We usually don't see that with children on the autism spectrum, right? And there's also the deficit of social attention in terms of being able to focus a lot on faces. Young children, the way the brain of the developing child is wired is to have a preference for human faces. right? But when we have children with autism spectrum, there's that deficit in social attention. So the child can be with you because parents say that, oh, my child plays with me, we play. But when they come for observation, what we notice is, so the child is interacting with the parents, the child is playing with the parent, but the child is not looking, not making eye contact, not sharing anything, not smiling at the parents, right? So we see that disconnect in terms of social attention. There's a tendency to be more focused on the objects that the child is playing with. So that's another thing that we look out for when we have very young children come in. And like I said, another key marker, of course, is the absence of engagement skills. I want to, when parents come, you want to be able to look out, okay, so when your child is playing, does your child bring stuff to show you? Children like to show off, right? I tell parents that a lot because they want to feel that sense of achievement, the sense of pride that, okay, I have made something happen. So they want to show you, they want to bring the things to you, they want to show you, they want to get you involved in what they are doing. But we don't see a lot of that happening with children on the autism spectrum. And at this point, I also would like to make that little differential in terms of the pointing, because that's another place parents tend to confuse one of those markers. So parents will tell you, oh, my child points. And then you ask them, show me how your child points. And they show you the wrists nudging, right? If you can see my hand. So usually they will show you the wrist nudging, but that's not actually what we call a point clinically. A point is when you extend the index finger out and you try to point in the direction of something. And in terms of joint attention, that usually would come with eye contact. So all of those things usually tend to be missing in very young children with autism, right? There's also the lack of that sense of pride. So a child has done something. Some of them are on the excessive side. They want you to clap at everything they do. But there are some, even when they've achieved something difficult, you clap and you say, hooray. The child is oblivious because there's no emotional connection, right? So these are some of those markers we are looking at. We're looking at eye contact. We're looking at imitation. We're looking at proper pointing. We're looking at social attention, a preference for human face. We're looking at joint attention, the presence of the 3-point gaze, right? We're looking for all of those things. And when we have a child that is coming in for an assessment. So beyond the language that is very, very distinct and tangible for parents to see, we also want to be able to see these things happening before we can say, okay, this child is not at risk, or the development of this child is typically progressing. Thank you.
Hey, thank you very much, Mrs. Okerapo. Straight away, we'll move next to the next question. There were some things you mentioned that I think we should take the next question immediately. Now, with all of what you have said, 3-point gaze, preference for human face, imitational skills, and all of that, the next thing I'm going to ask you is, are there readily available tools to screen for autism in young children? And how accurate are these screening tools? I'll take it again. Are there readily available tools to screen for autism in young children? And how accurate are these screening tools? Mrs. Okerapo, you have the floor.
Yes, yes. I think Dr. Boyede mentioned the MCHATs, the modified checklist for autism in toddlers. And usually we, when children present and all of that, the first thing is to check all the normal developmental milestones, right? You want to be sure that progress is going on there. So you usually would not jump into an autism screening when a child presents. So of course, there's the ASQ, there's the PEDS, Parent Evaluation of Developmental Status, there's the MCHAT, and I think recently there's another screening tool. I'll have to look that up and get back. There's another screening tool called the PEDS, developed during the COVID period, that you can use virtually to screen for autism. Apart from the parent evaluation of developmental status, there's another PEDS specific to autism screening. So yes, they are available. And how accurate are they? So first and foremost, these are tools that first and foremost just help you as a parent know that, should I still check this? At the end of the day, it's still important for that parent or whoever to consult with a qualified professional before you can say, okay, this is accurate or not. To a large extent, from my own experience, those tools are able to pick up to about 80–85%. But in some instances, the truth is some other presentations might camouflage as autism. And that's why it's always important, beyond taking a screen online, is to speak to your healthcare professional that has a background in terms of autism assessment and evaluation. Because we've had cases of children who have screened for autism and actually did fail the MCHAT, either because parents did not really understand the behaviors, right, that the MCHAT was trying to test, or these children were at risk of either ADHD or some other developmental difficulties, but they also failed the PEDS, right? So sometimes, yes, but at the end of the day, it is very critical that you check. If as a parent, you have access to all of those tools, they'll always tell you that this is just to let you know that you might need to go check with your healthcare professional. And of course, for the MCHAT, is actually a 2-level thing. So even doing the first level is not enough. You still have to do the second step of the MCHAT, the follow-up MCHAT, right? So when you do the first one, the child fails it, you do the second one, it's time for you as a parent or as a general practitioner to speak to someone that is qualified to assess autism. Yeah.
All right, thank you very much, Mrs. Okera. For now, I would like our audience to know that we see your questions. Some have sent in questions to the Q&A section. I'm going to read out the questions. Now, we still have quite a number of questions that our panelists are yet to answer. That's the reason I have not taken your questions yet. So please just listen, because a lot of times what happens is that the panelists answer the questions in the course of the program. Another thing is that if we begin to ask the questions, we may jump ahead of ourselves. So please just listen, keep listening. Your questions may be answered, or most likely will be answered in the course of the programs. For instance, I have somebody here who is asking, how do you interpret the behavior of a child who likes to write in the air? He doesn't respond when you talk to him. I think Mrs. Okeriafo has touched on something like that. Now, not necessarily writing, but when she was talking about the fact, okay, he plays with the parent, but it's not playing with any other person. So it looks like something similar. But you could just keep listening in case most likely the question will be answered. I have another person saying another child talks at home according to the mother, but doesn't talk in school. What can be the reason? You just heard that. So you see what I mean, that by saying sometimes the questions are answered. Okay, so you can see that a question was just, Mrs. Okerafo just answered this particular question now. Adekemi, your question has been answered. Adekemi Ogunode, the question has been answered. I have a question, another question here says, my name is Ugochi Madbiki. I'm an educationist. Most times we come across children with the traits you have highlighted, and during discussions with the parents, they say the doctor handling the child's treatment says the child's milestones are late developing. Please, I want to be clarified on the difference between late milestone and autism. I think Dr. Boyede talked on something like that, but please just stay tuned. We're going to touch on that. Aderonke, Dr. Boyede should please give us the diagnostic dimensions or tools again. Mrs. Okera just mentioned it again. We talked about the MCHAT. But she could say it again in her next question. Then Adachiku says, is autism disorder a lifelong disorder? Adachiku, just stay tuned. That question will be answered, okay? So I see your questions, but we are yet to touch on a lot of questions. And notice I had to ask the panelists to begin to answer their questions in 2 to 3 minutes. Trust me, we haven't covered half of the questions here. So just stay tuned, your questions will be answered. Roja Samson, I see your question, it just came in. Can professionals come together form what was that? Let me see, what was it you said? Can professionals come together and form general assessment to which can be sent to the government? Okay. Who is another person just said, please, what is the right doctor to see? I was asked to see an ENT doctor. I also feel the process is slow. The ENT doctor gave me a 4-month appointment after the first to do a hearing test. I'm sure that's what you meant to say, test. Okay, so stay tuned. Your questions will be answered. Okay, I think Mrs. Oranyi already mentioned something about that, but don't worry as the questions go on. Dr. Boyede, please, I'm back to you. What are the recent findings in autism diagnosis? That is, what has changed with regard to the age we can safely diagnose a child as having the autism spectrum disorder? Should I take it again? What are the recent findings in the autism diagnosis? Now, specifically, what we mean is what has changed with regards to the age we can safely diagnose a child as having an ASD. Thank you, Dr. Boyede.
All right, thank you so much, and thank you to all the other panelists. I mean, it's been quite insightful session. What I would like to say is that in terms of the age at which we can diagnose autism, nothing has really changed. Most of the time, parents can actually begin to see signs before the children are before they even turn 1 year old. But because of the process by which we have to take the child through to have the assessment completed, most children will be diagnosed maybe around 18 months, 2 years old, as early as that. But I've seen mothers who could tell me that even by 6 months, 9 months, they already know. Mothers are very intuitive. They already know there's something wrong. But following every country, every hospital or centers have their protocol for doing an assessment. For example, we need to do an hearing test. We need to make sure the child does not have any hearing loss and all that. So those processes, seeing the pediatrician, doing all those things, may take time. But most children will be diagnosed around the age of 2, most times 3 as well. In terms of autism itself, autism diagnostic criteria are always changing. The way we classify autism, the way we diagnose autism somehow have changed. So in 2013, was when DSM-5 criteria was released. Before, we used to do what we call a triad kind of diagnosis, but now we've kind of make it what we call a diagnosis, just two major category, the A and B, which I've referred to earlier. So that is what is changing. So sometimes the way we diagnose autism changed, and then the way we label it. So before, we used to talk about high functioning autism, we used to talk about Asperger's syndrome, Rett syndrome, all sorts of should I do dissociation and all those stuff. But now we've done away with all that. So we don't do that anymore. So everybody is on the autism spectrum. There's no high functioning, low functioning, Asperger's, blah, blah. We've removed all that. Everybody is just on the autism spectrum. So those are for me, I think those are the changes that have happened since in the last 2013. And since then, nothing much has changed anymore. Thank you.
Thank you so much, Oboyede. Thank you. And I appreciate the fact that you're sticking to the time. Thank you. Thank you. Mrs. Oranyi, my next question is for you. Now, my question is we know speech therapy is one of the services required for children with autism spectrum disorders. Now, what are the distinguishing features of speech therapy when a child has ASD from when a child doesn't? Like, is it different? Are there specific programs for children with ASD? Okay, should I take the question again? Okay, so we know that speech therapy is one of the services required for children with ASD. What are the distinguishing features of speech therapy when a child has autism spectrum disorders from when a child doesn't? Now, are there specific programs for children? Are there specific speech programs for children who have autism spectrum disorders? So is it different when a child does not have an autism spectrum disorder? Is the programs, the speech program? Mr. Oranyi, you need to touch on the microphone symbol, otherwise you'll be talking and we will not be hearing you. Or admin, you can unmute her, please. Okay.
Can you hear me?
Hello, Ms. Oranje, can you hear us?
Yes, I can hear you.
Okay, so we're kind of struggling to hear you. We don't know if it's the volume or if it's the network, but we know you're talking. Your mic is off again.
Okay, so it's on.
And okay, so, all right,
Can you hear
okay.
me?
Yes, we can hear you now. Yes, we
Okay.
can.
Okay, so like I was saying, autism comes in different, we have different types. We have children that are verbal and children that are not verbal. So depending on what presentations, what behavior patterns that the children present, will determine what
Sorry,
patterns
Ms.
of behavior.
Oranje, please. Hello, Ms. Oranje. Ms. Oranje,
Yes.
we're struggling to hear you, or I don't know if it's just me. Can everybody hear her clearly? I am struggling to hear you, so I want to be sure it's not the same for the audience and the other panelists.
I think it's muffled a
And
bit. We can't
everybody
hear.
here.
No, we can hear.
Okay, we can.
Can you all hear me, please?
No, we cannot hear you.
At all? My goodness. So what is happening?
Now we
there's
can.
We
nothing
Now we
can
can
hear you
hear
now.
Now we can
Now
hear
we
you.
can hear you.
Okay. All right. So
Now we can hear you.
okay.
And
All
please,
right.
before we go on, I'd like to say to the audience that Mrs. Okerafor has listed the specific screening tools in the message section, so you can just check it out. For the person that asks for screening tools, it's in the message section now, so you can check it out. Thank you. So, Ms. Oranje, please go on. Are you using an earpiece?
Yes. Yes, I am.
Ms. Oranje, are you? Okay, so we
Yes.
can hear you now, so perhaps the earpiece works better. Okay, so please go
Yes.
on.
Okay, so like I was saying, autism comes in different, it presents itself in different ways. We've seen children that are verbal and children that are non-verbal. So depending on what presentations that children bring when we see them, will determine the kind of speech therapy that they would be exposed to. Now, for example, like you had mentioned, there are different types, apart from the normal speech therapy processes that a child is being given, the intervention processes. There are also other intervention strategies that children on the spectrum can be given. For example, the ABA, the Applied Behavior Analysis Therapy is given, all right, where children's behavior is modified. And inside that ABA program, you have a speech aspect of it. All right. But at the same time, when a child is being given, when a child is exposed to the ABA therapy, they also, do speech therapy at the same time. Now, there's also the teach. Now, this is a clinically, by teach, I mean TEACCH. It's an intervention program from the University of South Carolina in the US that also helps work with children. It's a more it's more structured in the sense that children are, exposed to a more restrictive environment where they are they learn language. But what I would we usually encourage during speech therapy, or what we always do during speech therapy, is to look at those behaviors or those pre-linguistic skills. Now, by pre-linguistic skills, I had mentioned them before: joint attention, imitation, eye contact, that are missing. Those are social skills that children actually require to master language that are missing. Those skills will form a major part of the speech therapy session. Now, you can't start a speech therapy session for a child that is non-verbal by saying, oh, say dog, say cat, say book. For a child that has never spoken anything in his life, it's usually not the right place to start. And I always tell parents that when a child is non-verbal, you look at those pre-linguistic skills, those skills that you master before you start speaking. For you work on those pre-linguistic skills before you even start exposing that child to speech. Remember, it's a neurological difference, and language is a cognitive skill. So when those skills are missing, it's usually a challenge for you to start teaching a child to talk without looking at those other areas that I had mentioned: imitation, joint attention, eye contact. The child has to be taught all those before you now move into the speech aspect of the therapy. I hope that answers the question.
Okay, yeah, thank you.
Okay.
Thank you very much, Mrs. Oranye. Okay, thank you. Thank you for also doing your best to stick to time. I know it's not easy. When you in our field, you tell someone to answer something within 2 to 3 questions, it just automatically gives more work. Now, for the teach that Mrs. Oranye mentioned, please look in the chat. Ms. Sukira just put it there again. Thank you. So you will do, my wonderful audience, you will do well to keep checking the chat. Some of the answers to your questions are being written there. Thank you again, Mrs. Sukira. Mr. Fakorode, my next question is to you. Now it says, Mr. Fakorode, can you hear us?
Yes, I can hear you.
Okay, yeah, finally we get to see your face. Good to see you. So the next question says, there's sometimes confusion between autism spectrum disorders, ASD, and attention deficit hyperactivity disorder, ADHD. Can you please give us more insight as to the difference between the two from the perspective of an occupational therapist? Should I take the question again?
No, you don't need to take it again. That's fine.
Okay.
Yeah, so
all right.
When we talk about
great.
ADHD, so we're talking about attention deficit hyperactivity disorder. Okay, so and then when you look at the characteristics of ADHD, which is attention deficit hyperactivity disorder, you're looking at 3 things. You're looking at the inattention, you're looking at the hyperactivity, and then there must be presence of impulsivity. Okay, so whereas when you look at ASD, it is associated with impaired communication, social interaction. In addition to this, you see repetitive and restricted behavior. But at times, you see both attention deficit hyperactivity disorder and autism, because they are both neurodevelopmental conditions, okay? So they frequently co-occur. They frequently, in children with, according to research, in children with ADHD, with ADHD, they present about in 30 to 80% of individuals with ASD. You see, do you get what I mean? So children, ADHD is present in children, 30 to 80% of children presenting with ASD. And then for ASD is present in like 20 to 50% of individuals with ADHD. So what are these characteristics, or signs you're going to see in these children? So for children with ADHD, you basically see what we call being easily distracted. You see it in ADHD, whereas you might not see it, might not necessarily be with children with autism. Frequently jumping from one task to another, having it in mind that this condition might co-occur, but when you're looking at a child with basic ASD that is not having, comorbid ADHD, the child might not be easily distracted. So I'm talking about ADHD now. The child might be easily distracted, frequently jumping from one activity to another, and then unresponsive. When you see a child that is unresponsive to stimuli, then you want to go to ASD. You will not see a child that is having ADHD not responding to stimuli because they don't have any business to do with anything sensory. If autism is not comorbid with them, difficulty in focusing and concentrating or paying attention, you will see it definitely in ADHD, but then you might not see it in ASD. Okay, intensely focusing on single or particular object is definitely in ASD. You say a child with ASD focusing on one, they are just wanting to focus on one particular object. But then in a child that is very hyperactive, they don't even have time for that. Okay, so hyperactivity, of course, is present in ADHD, but you might not necessarily see it in a child with autism spectrum disorder, or else the child is seeking for movement. You get? So unless it's the sensory part and the child is seeking for the movement, then you might want to be confusing like, oh, this child is hyperactive. But that's the reason why I'm given this clinical criteria that you might want to look into before you say this child is having ADHD or the child is having ASD. So troubling sitting still. A child is not sitting still. You might see a child with autism sitting in one place and not wanting to get out. But with ADHD, they're just everywhere. They're jumping everywhere. Unless the ADHD is present in a child with autism. Interrupting people's conversation. You see it in a child with ADHD. They always want to interrupt your conversation. But then autism don't have time because they always want to be on their own. They don't even have enough language to even string those words to come and interrupt you. They don't. Once you're not with them again, they're busy with in their words. Okay. Both of them, when you look at them, both of them lack the ability to react to other people's emotion. For ADHD, is because of their inattention and their hyperactivity. For ASD, is a different thing. Okay. For ASD, the ASD deals with more perception and then more interpretation of those things. Repetitive movements such as rocking and twisting, you will not see it in ADHD, but you will definitely see it in ASD. Okay, so avoiding eye contact, you will not see it in ADHD, but then it's there in ASD. Withdrawing behavior. A child with ADHD will socialize and then they will play with you, they will even disturb you, but then you will not see. Withdrawing behavior is definitely in the children with what I call ASD. Impaired social interaction. People with ADHD does not have even a problem with socializing, whereas you see it in children with ASD. Delayed developmental milestone. You will not get it in ADHD, but you get it in ASD. So when you look at this, unless it's entering each other, unless there's comorbid or ADHD or comorbid autism, then you might want to see all these clinical features in a child.
All right, thank you very much, Mr. Fakorede. While I'm tempted to go to Mrs. Okerafor, you said something about sensory processing issues, and so I'm just going to take you up on the next question. The next question is sensory processing difficulties. First part of this question is, do all children with ASD have sensory processing difficulties and vice versa?
Okay.
So does it mean that once a child has sensory processing issue, the person is on the autism spectrum, or can neurotypicals have it as well?
Okay, so the word sensory processing difficulty, you can describe it as like the challenges that you see in or children with autism. Okay, it affects their brain, how their brain interprets sensory information, because they receive it differently. So, like I said, the way children process sensory information has now been added to the criteria you'll see, which is linked to the restricted behavior and then some repetitive behavior. Okay, because from years of experience, you see from observation, like a child that might be having restricted behavior or repetitive behavior, you might want to link it to some sensory processing difficulty. A child that wants to be alone to avoid a lot of things around him. A child that wants to be alone, that wants to cover his ears to block the noise. So if a child is on the autism spectrum disorder, yes, they have sensory processing difficulties. It might then be mild in some, moderate in some, and severe in others. But you cannot rule out, like I said, you cannot rule out what I call sensory processing difficulties in children with ASD. Because you have to then link it to that restricted behavior, repetitive behavior, and then, so most of these senses, most of our senses, we combine them together, okay? They are combined together: sight, sound, smell, touch, taste, balance, and then awareness of body position in space, okay? We need to use it to make sense of our own environment. This is why it's a difficult thing. You might not see it in children with in neurotypical children, okay? And then at times, when you look at a child that, I don't want to go to talking about early diagnosis now. So I'm trying to actually streamline most of my answer to the questions being asked. You get, so I don't want to go talking about the early diagnosis or talking about how early intervention is important. But then, like I said, they use it in order to make sense of their own environment. And then you see most children with autism having difficulty filtering this information. They have it. So yes, to your question, my answer is yes. Most children with ASD, autism spectrum disorder, they have a bit of sensory issues, which might be mild, moderate. Some children are able to manage their sensory needs, whereas some are unable to manage it because of the affectation, how deep it has affected them. So they might need some professional input, whereas some children are able to manage it. They know strategies around it. They've been taught ways because it's mad, it's not really affecting them. So you might not be, if you're not a professional, you might not be able to recognize that.
All right, thank you very much, Mr. Fokke. Thank you, thank you, thank you. So after, I'd just like to say to the admin, after Mr. Okerafor's question, let's have the poll for the second question. So Mr. Okerafor, over to you. Now, sometimes parents have a hunch about their child, and when they talk with clinicians, they are told to wait. What would you advise such parents in line with all that has been discussed so far? So if a parent comes and says, I was told to wait, what would you say to such a parent? Mr. Kira, for you with us?
I am. Thank you. I think Dr. Boyd did mention it at the beginning of her addressing some of the questions you asked. So yes, we get all of those feedbacks sometimes when parents come in, okay, because the parents are worried. They know all is not well with the child, right? In as much as parents are not professionals, but a parent's hunch should not be discountenanced, and that's very critical. So for us, I think when parents come to us, the first thing I want to do with that parent is first and foremost to affirm their concerns, right? I want to affirm their concerns, because for a parent to leave their place, don't forget that this particular parent in question lives in a community. In Africa, we look out for one another. So this parent is already in a community where she has seen, or he has seen, other children, right, that probably were born at the same time that their own child was born. So sometimes they've even delayed before they are coming to you, because we also know in Nigeria, we say, oh, he's a boy. Boys are usually like that. Boys don't talk fast and all of that. So parents have surmounted those obstacles to come to us to say, oh, I still believe something is not right with my child. So in such an instance, while we may not rush off to say, okay, let's do an assessment, we usually would want to say, okay, can we even do a first line screen? Okay, if we do a first line screen, either we do the PITS or we do the ASQ, and we find out that, okay, this parent's hunch coupled with observation, of course, because the PITS or the ASQ is still a parent's reported impression of their child. So you also want to be able to take some time to really look at the child in terms of all of the things that have been discussed today. What are those other factors that we should be looking out for beyond the tangible milestones, the sit and the neck control and all of those things? And then even when it's still uncertain, right? Maybe because the child is very young, or as a clinician, we didn't get enough time, or you don't have enough time to really, really evaluate that child. The least we can do, which is what I always advocate for, look for developmental promotional activities, right? And this is very critical, whether it is autism or it is just a global developmental delay. Whatever you do within the first 3 years of life is very critical, right? So when parents come to us and we don't want to be in a hurry and the lines are not very clear, but we know that there are significant delays, there are notable delays, is first and foremost, go and do some stimulation. We first and foremost want to know the home environment, what's going on. And a lot of times we'll find that there's a lot of binging on technology. There's minimal interaction in the home. There are so many things that do not come together to create an optimal developmental atmosphere for the child. So we first and foremost want to screen the home environment and also be able to give the parents tools that they can begin to work with. And then before we schedule them for the next visit, when we can see again to know how much progress the child has made in terms of response to whatever recommendation that we have made. So I always say, don't just ask a parent to go and wait, right? There are things that you can advise the child, there are information, there are resources we can share with parents. Go and do this with your child, go and stimulate language, go and minimize TV time, because it's an erroneous belief out there that, oh, once I can put my child in front of Coco Melon, my child can hear language, speech will come. But the research has shown that the brain does not develop language based on technological feedback. Language is developed based on human feedback to the brain. There has to be that back and forth interaction. So first off, what we'll tell parents is, okay, we've looked at the environment. These are things that may be impacting upon your child's current presentation. So let's manage these things. And then you as a parent, you can begin to do this. So we usually would tell them to go and start off a few things and also begin to interact more with your child. It's very critical. We tell parents, begin to interact more with your child. 5 minutes, 10 minutes, 15 minutes, use the routines and all of that. So those are some of the things that we don't just ask them to, oh, go back with your doctor says. No, we want to listen, we want to see, and then we want to be able to provide that first step guidance for them to just start up something that we can measure the impact when they come back to us. Thank you.
Would take up the post, but because you mentioned something, let's just go with the example. So this next question says, since we're talking about the diagnosis and the identification, some children were identified early and actually did start early intervention, right? Yet we have cases of very slow recovery for them. So what are some of the reasons behind
Sorry, your line is breaking.
poor outcomes for such that early intervention is key? And can any hear me? Can anybody hear me?
Oh, we can hear you, but it's breaking.
Okay, so, but can you hear me now?
Okay, yeah.
Yes, we can hear you now.
Okay, okay, I need to be sure it's not my earpiece. Okay, so I said, in as much as we said we're going to take the polls, but I needed us to answer this question immediately since you already touched on it. And the question is, we've had cases where children started intervention early because we have preached and said early intervention is key. And we have, we have seen that statistically. Yet we have cases of children with very slow recovery, even for those who were identified and actually did start intervention early. What are some of the known reasons behind poor outcomes for such children? Mrs. Okerafor?
Okay, sorry. Yeah, okay, so poor outcomes for children, even in the face of early intervention, right? Okay.
Yes.
Okay. I think basically when it comes to treatment outcomes, there's a lot of things that could affect the outcome. So now we're talking about early intervention. First and foremost, a lot of people think early intervention is okay, 5 years, 8 years, and all of that. No. So first and foremost, what's the age that we're talking about? So for early intervention, we're talking about from birth to about 5 years. And if you push it a little further till about 8 years, depending on the country that's you're seeking services from. So that's the first factor when they come in. Then I think the next thing is also, which is very critical, the symptoms that the child presents with, how severity of symptoms, right? So with autism, you would have a mild, you would have a moderate, you would have a severe presentation, right? So how each child would progress would depend on the first level of what we saw, right? Where is this child? For children that are very severe, treatment outcomes are usually very draggy, right? Because a lot of times these children would have significant intellectual disabilities, right? So when you have all of those things going on, and some of those children that fall in the severity also have high sensory processing needs, right? So symptom severity is also a factor. So when you move away from that, you now go on to, so you've moved away from the child and the age at which the child comes to you. So you're not looking at what is the quality of the intervention, especially in our own clients, right? So that is one area that we're still building capacity. We're not there yet. There's still a lot of gaps in terms of programming and what is available out there. So what is the quality of the program? What is the sort of program that this child is? There are programs that have been shown to work, right? There are programs that have evidence behind them to say, okay, for a child on the autism spectrum, this works. But what we have a lot of times, depending on what the child sees first, from my own experience, right? What you have is, okay, so the child makes that first contact, the diagnosis is made, and they say, go and do speech therapy, right? Autism is something that is multifaceted, right? It affects cognition, it affects adaptive skills. So go and do speech therapy may not be sufficient, right? But if that child is fortunate enough to come into a program that is evidence-based and qualitative, the first thing you will be told is not just speech therapy this child would need. The same way we have different professionals in this place now talking, that child will have to access services from speech therapy, applied behavior analysis, a developmental psychologist, a pediatrician, depending on what the child is presenting with. But it starts from being able to access an evidence-based program. And then what is the structure? I've seen a lot of situations where people come to me and they say, oh, my child was diagnosed, and they say, okay, I should get a facilitator, right? Facilitation is complementary to core therapy sessions, right? So when there's that disconnect, when there's that gap already, so first and foremost, it has to be multidisciplinary. It also has to be structured in such a way that learning support is going side by side with core intervention, because I always will tell parents is learning is not where your child starts from. You have to have a solid developmental foundation for your child to build learning upon, right? If there are gaps in terms of language, your child may not be able to read well. So you want to be able to have therapy that goes on to solidify that foundation for your child. So you also want to look at the quality of the program, and also this is also key. We're looking at family involvement, okay? How involved? Because when we talk about family involvement, it goes beyond families and parents knowing what is happening with their child. Okay, just to be sure that the money that they are paying is actually being utilized and it's working for them. No, every child that the therapist is working on, every skill that the therapist is working on, somebody has to be able to help the child to generalize the skill. I tell parents, your child does not live at my therapy table. Your child is not going to function from my therapy table. Your child will go to the supermarket. Your child will go to church. Your child will go to school. So who is there to help the child to generalize the skills from the clinic setting to the community? Do you understand? So when all of these gaps come together, outcomes for that child will definitely be impacted, right? However, if we're able to cross all of these T's and dot all of these I's, to a large extent, we may not have such a situation. Because why we call programs evidence-based is because some people have put those programs through the test and they have data to back up those programs to say, oh, 10 children did this program, and out of the 10 that did the program, this is the success rate. That's why they're called evidence programs. And it means they have systems and structures that have been tested and tried over time and have proved effective. So when you have a child that starts early intervention, you want to begin to look at this lineup of possibilities, what's going on along this rung of things that I've just mentioned. Thank you.
Okay, thank you very much, Mrs. Okera. For we have the poll for the second question up. I would like to please ask the participants to please, our audience to please participate in the poll. I'm looking at, okay, so I see that the number of participants is increasing. Maybe we should take it out a bit. And so until then, this question, the second question is for this poll has to do with speech. So I was thinking that Dr. Oranye will take my next question, but since people are still participating, Dr. Boyede, I will come to you. Now, as one of the founders of one of Africa's largest pediatric foundation, what would you gauge the prevalence rate of autism in Nigeria? Dr. Boyede.
All right, thank you so much. Like in many conditions, we really don't have data in Nigeria as to how many of our children actually have autism. We don't. However, there are a few researches here and there, and one of my resident doctors did a research in 2019. And because when you're talking about autism, we are not looking at it in the hospital, those children who already came to us as having autism diagnosis. So we're trying to look at everybody, that is when, so when people say in US, it is one in, I think it used to be one in 69, and maybe it's one in 44 children now, or in UK, it's about 1 in 100 children. They have data because they know all their children, and then they can say, out of all these children, these are the number of people that came down with autism. So we tried something like that. So we went to the school, we screened like about 1,500 children with the M-Child, and then these are children that have not been diagnosed with autism. These are children whose parents are not even concerned. So it was just screening apparently healthy children, and then we screened them, and I think about 56 of them actually have a high scoring on the M-Child enough, and we took them through the assessment process. And I think at the end of the day, we have just about 2 of them finally been diagnosed with autism. So which means I think it's about 0.1%. That was just in Lagos State in a cohort of 1,500 children. So giving the impression that actually it is not a very high rate, in Nigeria. But then this is just one study restricted only to Lagos, looking at elderly children, but we really don't have the exact figures of the number of children that actually have autism in Nigeria. It's one of the things we actually need to do a research on. But for those who come to the hospital, the rates could be high. For those who are already coming to the pediatrician, so these are people that the parents already have concern and they've come to you. So those are the studies people have published. And so sometimes it can vary from, some have published as high as 3%, some as high as 35%. But then remember, these are population of those who have already come to the hospital. So definitely the rate will be higher. But when you look at the general population from that study, we'll say it's still less than 1%, but we cannot generalize. But that is just our own modest attempt to try and see how prevalent is autism in Nigeria.
All right, thank you very much, Dr. Boyede. So I'm just going to throw this next question at you. Okay. I see that people are still, the participants are increasing. So I'm just going to pause because I don't want Ms. Soraya to have to come back to this. So, but following what you said, now this question, looking at the fact that ASD impacts multiple areas of a child's function, how best can clinicians route referrals for children with autism? Now, we talked about the fact that unfortunately we do not have data. I mean, it's not just peculiar to our field. the country as a whole, but not knowing what to do or the data on ground, what's the best way clinicians can route referrals for children on the autism spectrum?
I think the first
Dr.
is that
Boye.
children that have autism or that are suspected to have autism need to come first to the clinicians. So we can't refer a child who has not even come to you. And I think that is why this kind of a program that we're doing today and talking to parents is so important. And I know that some other organizations also do a lot of awareness program, trying to let parents know, because we live in a culture where we believe everything is spiritual, everything is somebody afflicting me, everything is somebody sending arrows to my children. So people need to understand that every time when your child has difficulties in terms of development, it is not a spiritual attack, it's something medical that can be sorted. Two, people need to stop labeling all developmental condition as one. So people will say, oh, it is Down syndrome, oh, it is cerebral palsy. And I even see professionals do that as well. So there's no way you will know what developmental disorder a child has until the child has been seen by the right professionals and gotten and having the right assessment. So I guess that's where the professional now comes in. Like, when you should know your limitation. So if you are not trained and licensed to do those assessments, please refer the child. So unfortunately, we have very limited number of professionals who actually have enough training to do some of this assessment, but I'm happy at least we're seeing some of us here today. So I think it's the job of every professional to know in your state, in your location, where you can get somebody to do a proper assessment for a child and then now refer the child. But when I speak to my colleagues, when I speak to doctors, professionals, I always try to tell them, please don't reassure parents unnecessarily. People do that a lot. And don't just tell them there's no problem. And don't just tell them, know your limitation that you cannot do it. And don't just tell them a diagnosis when you know you've not done an assessment. I've seen some of the questions here today. Already parents are getting frustrated, like, which doctor do I really need to see? Some people go to the ENT. The ENT has no business doing autism assessment. The ENT person cannot tell you if your child has autism. ENT doesn't even supposed to be doing hearing test. You should go to the audiologist. That is the right person to go to, even for the assessment. So, but unfortunately, we also live in a culture where everybody is after their bottom line, the money they're going to make from patients, and instead of them. So I guess what we can do, because of time, is just to say, if you as a parent as well, if you're listening, you should know the right professional to go to, and just appeal to the professionals to make sure that you know where the children can get those assessments and refer them. And let parents know that this is what I do, but I cannot do this, but I'm going to send you to my colleagues who do this assessment. That's all.
All right, thank you very much, Dr. Boyede. Thank you so much. All right, I'm going to have to take the result of the polls like that. We're running short of time. I will try to just give an extra 15 minutes grace to see how much we can cover. Or afterwards, if your question is not answered, I see that already we are answering the questions that came in the Q&A section. If your question is not answered, I may have to ask the panelists to send in their email addresses, and I'm taking the liberty to say that you have 1 week to send in your questions to them, after which they may not take questions again that have to do, that will come from this program. But let's get to that point first. So this question says, I'm reading the poll. The second question of the poll: any child with autism spectrum disorder and speech impairment who undergoes therapy will eventually start talking. Let me read it again. Any child with ASD, that's autism spectrum disorder, and speech impairment who undergoes therapy will eventually start talking. 70% of the participants said true. 30% said false. Let's find out. Mrs. Oraye, so I'm going to throw my question at you, and then you can just within your 2 to 3 minutes as you're answering, just chip in which group of people are correct from this question that was asked. Okay, but the main question here, question for you now is, from your experience as a speech therapist, how soon can you clearly make a diagnosis? And how soon can intervention begin for a child at risk with ASD? So the question on the poll is going to be the part 2 of the question I've thrown at. First question, my question to you again is this: from your experience, how soon can you clearly make a diagnosis, and how soon can intervention begin for a child at risk with ASD? And after you have answered that, so let us know whether the people who said true are correct or whether those who said false are correct. Mrs. Orion, you have to.
Okay. All right. So can you hear me? Let's start with that. Can you hear me? Okay. Yeah. So
Yes, we can.
intervention
Yes,
should.
we can.
Okay. So intervention should start as soon as possible. Now, if a child comes in at 12 months and have those clinical markers for suspected autism, intervention should start as soon as it's noticed, because early intervention is key in working with children with autism. The longer it's delayed, the more difficult it is for the child to acquire speech and even every other behavioral signs that the child is presenting. So immediately the child is diagnosed, yes, intervention should start. All right. So research has shown now that 50 to 60% of children who have received early intervention as soon as a diagnosis was made actually, acquire speech and language later on. Now, there are still the other 40% are children, like we have mentioned, Mr. Cora mentioned the past during her presentation, children that have moderate to severe autism disorders. Now, there are some children that find it very difficult, to, for example, imitation. If a child has difficulties, especially when the autism disorder is severe to the extent that the child cannot imitate, the child cannot play, pretend, does not have good social skills, because those are prerequisite skills. I keep mentioning those prerequisite skills. If those prerequisite skills are missing and lacking in children, it's going to be extremely, well, let me not just use extreme, it's going to be harder for the child to acquire language. Okay, so not all children, I have to say it now, not all children with autism end up acquiring speech. Okay, because I have seen instances where children with autism do not, and that is why we have alternative means of communication. I tell parents this now that if you have, dedicated yourself to, getting the right intervention, all the strategies being given to you is being put both in school, both at home and, in the therapy room, and everything is done, and still the child is not talking. Start looking at the next steps, which is alternative communication. There's sign language there is use of augmentative communication devices, tabs and all that. And then eventually, we've also found that somehow these augmentative devices, addictive devices, kind of helps children. They might not acquire language to the point that they start conversing, they start having conversations like me and you, but to the point of getting their needs known, they can use those devices to express themselves. So this is what I want. No, this is not. I'm cold and all that. So they can use that. So for those participants that said it's usually difficult, I think it was 70% or 30% from the poll that said children that have gone for therapy eventually end up not talking. Like I said, it's possible. We've seen it happen, and there are also other methods in which you can get children to express and communicate.
All right. Thank you very much. Thank you very, very much. Now, it's 7 p.m. Like I said, it's a 2-day program. So we have another set of panelists, but clearly they are going to learn from my own mistakes. So there's also another set of hot people that will be coming in tomorrow. But very quickly, I want to see us wrap up in the next 5 to 7 minutes. So I'll just quickly go back to Dr. Boyede, and I'm going to run through all the panelists. Dr. Boyede, very quickly, do you think that with technology and the growth we're experiencing in the medical sector, what are the opportunities that hold for a person living with autism spectrum disorder?
I think there are lots of apps and support system, you know, things.
Okay, in 1 minute, let's hear it.
Yes, they will definitely be helpful for them, really. Of course, we're running now, so it's difficult. But there are some basic understanding we need to know about autism, and I think if we don't have that, because all those apps, they're just to help them in different ways, and I think that so definitely they will be helpful.
All right, thank you very much. Thank you. So in a nutshell, there is hope for the with growth that we're experiencing, and that's a lot of that should come as a consolation. We believe that in another 5-10 years, or maybe 3-5 years, we will have technology that can assist children with ASD. Zoran, quickly back to you. Do you think our society presents promising opportunities for individuals with speech impairments, whether or not they're on the autism spectrum? Our society, let's not look at it globally now. Let's be local in this question. Do you think our society presents promising opportunities for individuals with speech impairments?
First of all, there is still a lack of awareness, all right? And there is still a lot that, you know, there's still a lot that people need to know about speech impairments and how it depicts a person or an individual's quality of life. So in Nigeria, like you said, I have to be specific now to Nigeria. Information is there is starting to, we're starting to, would I say, learn and speak more about it, but I still think we have a long way to go in terms of sensitizing people, in terms of letting people know that, okay, if this person has a stroke, for example, all right, these are ways in which you have to, approach that person. There are lots of stereotypes, so a question I saw now where comedians make jest of stutters, people that stutter, or people that have, some form of a language impairment. So we need to understand now that when someone has a disability, it's not something that should be made fun of, because even us as individuals, we have one form of thing or the other that is, a challenge to us. So a lot of awareness still needs to be said. People need to be sensitized a lot more so they get to understand that people with language, individuals with speech should be,
all right.
One way or another.
All right, thank you very much. Mr. Fakorode, as for a seasoned occupational therapist like you, who has worked both locally and internationally, what are the opportunities individuals on the autism spectrum who have sensory processing difficulties in our society have compared to those abroad? Are we even close? Are we close? Given the fact that you've worked locally and internationally, just let us know as it is right now, so we'll know if we start praying. All right.
Okay. Thank you for your question.
Mr. Fakorode, can you hear us?
I can hear you. Can you hear me? Can you hear me?
Yes, loud and clear.
Okay, so
loud and clear. We can hear you loud and clear.
I saw a question. I saw a question in the Q&A, someone asking about how can I link the sensory processing to occupational therapy? Okay, so and then your question also talks about, if you repeat that again, are we close to, can you repeat that again? Are we close in terms of the sensory intervention they receive abroad to what they receive in Nigeria? Is that right? Is that correct? Is that correct?
Your mic is muted, Nkoye.
Okay, so sorry, I was saying that my question specifically is, are there opportunities for individuals on the autism spectrum who have sensory processing issues? Are there opportunities for them in our society compared to what you have abroad? And are we close, really? So it's like a two-part question. Are there opportunities for them here in our society?
Okay, so there are not many opportunities in Nigeria, whereas we are bit by bit we're getting there. Identifying the right people that can help you work as early as possible on the sensory processing, on the sensory issues. Okay, my actually help the child's development. It might help the child's ability, like once you've actually identified, even before the diagnosis of the child, the early intervention is also the key. Identifying these sensory issues and then working on them as early as possible. From the year of experience has actually helped some children to lead a good life in the classroom, at home, and then, it has helped them. But then, like I said, not many people understand this in Nigeria, and then not many people are able to distinguish or know what exactly they're supposed to do, or the amount of these activities, sensory activities they're supposed to do. We call it sensory diet. They're supposed to give a child. You see, I've seen a lot of people that, oh, I'm a facilitator. I do this, I do that. I work with children with autism. But I see them doing a lot of wrong things, So that's in Nigeria. So because they don't know the amount of sensory diet they're supposed to give when this child is being hot, when this thing is being painful, when the stimulus is being painful to a child, they don't know when to stop or what to do. That's because they're not able to distinguish it, or they don't know the right diet, the right sensory diet they're supposed to give. But then it's also important to work on the child as early as possible. There are some centers and then some schools in Lagos that have professionals, like the CDC, they have professionals that can help you with that. Finding the right people, finding the right professional, we actually help. But then we cannot compare it. We cannot compare it to what is what we receive abroad to what is going on in Nigeria. But with more awareness and then more opportunity like this, I believe we can do more positive thing in the life of these children. So that will make me go to the question that I saw about linking the sensory processing difference to occupational therapy. So to the person that asked the question, when they say the word occupational therapy, you saw in the hospital that what they taught you is about how the child is going to use their hand or do things with their hand, and then make things, activities that they can do in future. Okay, so I want you to know that the reason why I mentioned this sensory processing and then the link to the occupational therapy is this. Any problem, so the word occupational therapy is the fact that your occupation, what you do on a daily basis, what you do as a doctor, what you do on a daily basis. Now you have a condition. How has it affected your occupation on a daily basis? How has it affected your routine? So now for children on the spectrum, you see that because they have issue processing information, because they have they have issue relating with others, communicating and all of that, it then affects their routine. It affects their ability to actually perform those things that they show you in the hospital, how to make those activities. It then affects it. Take for instance, a child that is having or what's that called? Joint attention issue, or we call it proprioceptive issue. That's awareness of body position in space. Handwriting might be very difficult with that child, whereas to other professionals that they don't understand, they might think the child is having muscle problem. When you check the muscle strength is 555. You get the child is definitely not having muscle problem. Then let's see a physiotherapist and all of that. So the child might be having joint attention issue, awareness of body position in space. Writing might be difficult. Eating might be
And it
difficult.
could be mistaken for dyspraxia.
So yes, you get what I mean. So so this is the link. So because those sensory processing difficulty is then affecting the child's ability to function, is affecting the child's ability to participate in the routine. Imagine a child that just wants to fixate on one particular clothes, on one particular food. Are you not going to worry? Are you not going to get worried as a parent? That's the reason why now, because it's affecting the child's occupation, that's the reason why occupational therapy, you see them work in the class, you see them work at home with the child, because you have to also to look, you have to look at the natural environment to work with the child, not only in the hospital. What they will teach in the hospital, as a matter of fact, they don't, as a matter of fact, wait. As a matter of fact, they don't have enough time to.
Mr. Sam, I'm sorry, I'm going to have to cut you here.
Okay, that's fine. All right.
Okay, thank you. But I'm sure you have. And first of all, I would like to say thank you to you and all the panelists. Without me even saying it, I noticed the panelists were going to the Q&A section and answering the questions from here. Well done to my panelists. Kudos. I really appreciate that. Thank you. I think it's safe to say a lot of the questions in the Q&A section has been answered. However, I'm going to plead with the panelists to please drop in their email addresses. So if you have any question that was not answered, and given the fact that all the questions we had were not taken, I would like to let the audience know that you have 1 week between today and next Saturday to please send your questions to them for free. Afterwards, you will need to book sessions to see them, and you know what it means. You've seen what these people can do. So, Mrs. Okerafo, I'm going to direct my last question to you, and then you can please close the webinar for today. So my question is, do individuals on the autism spectrum in our society even have opportunities at all? And if they do, what are these opportunities? Mrs. Okerafo.
Yes, thank you, Nkoye. It's been an amazing time here, but that's your last question. Is like WAEC and JAM put together. Do individuals with autism spectrum disorders have opportunities? Why not? We may not be where the Western society is at, but trust me, we are not far behind, so much so because over the past few years, there's been a lot of advancement in terms of identification and treatment options that are available, which by God's grace, we'll hope to talk more about in tomorrow's session. Yes, they do have opportunities, but primarily, like Dr. Boyede said, we have to first and foremost meet them. They first and foremost need to come and be diagnosed, and then we can then begin to say, okay, what are the treatment opportunities that they have? Because when you talk about opportunity now, bringing it to the theme, the global theme for this year, right? Workplace inclusion, right? At the end of the day, we're looking at a situation where the child that was diagnosed at 2 is able to go through intervention and becomes an adult that can contribute validly to society. Yes, to that extent, we are beginning to see a way being paved in that direction. We have people here today that have talked so much in terms of identification and all of treatment options. It starts from there, right? Research shows that usually when children come into early intervention, they are able to make gains in adaptive skills, cognition, and language, which are very key in terms of academic performance and academic success. So from academic success, these individuals can now begin to access job placement. And then we are able to say, yes, they can be included. Nobody includes anybody out of pity, right? People are included based on what they can contribute to society. So yes, it may not be where it should be, like in terms of countries that kicked this up long and way before, but we are seeing a lot of progress. A lot of people are becoming certified in applied behavior analysis. In recent times, developmental behavioral interventions are coming in. All these are evidence-based programs, and we are seeing a lot of certification programs going on. We are seeing programs that train parents and all of that. That's massive, right? In my view, that's massive. We're making progress. We are not there, but we're getting there. And so, yes, there are opportunities, and it will get better as we go on. We have to appreciate where we're starting from to be able to reach where we need to get to. Thank you very much.
Hey, thank you. Thank you again to our panelists. Thank you to my audience for giving us extra 15 minutes. We really appreciate it. Remember that it's a 2-day program. Same time tomorrow, we'll be here again with another set of very hot panelists. As a matter of fact, I don't know if the flyer is out. We're going to have parents who have walked this journey. So in case you're a parent here and you're losing hope, you're going to have a parent, a set of parents on the panel, and we'll hear from Have Education. So please, you don't want to miss tomorrow's session. It's going to be fire. All right. Thank you very much to my audience again. Thank you for giving us extra time. Thank you to my panelists. You were just wonderful. Thank you so much. Mr. Kira, to you. Please close.
Okay, thank you very much. It's been amazing. Thank you to all our wonderful expert panelists. We appreciate you. We thank you because you have made today very worthwhile. The amount of information that you have pushed out there cannot be quantified. So thank you, Dr. Boyede. Thank you, Mrs. Oronye. Thank you, Mr. Fakurode. Thank you, Mr. and Mrs. Okolo. So their session is tomorrow, but they came and they stayed in. Thank you, Adelola George. Thank you for your presence. And I think Mrs. Oshikoya was here. We do appreciate all of the learnings that has happened here. It's been massive. It's been very, very massive. And like we actually the flyer was not able to convey the magnitude of what just happened here today. So thank you very much. We deeply appreciate you. We thank you and we hope to see you for subsequent editions, right? And to all attenders, thank you. Thank you for making it today. And please don't just take the information for yourself. The whole essence is we want an informed society. We want to be able to give each other the knowledge we need to help every child, every Nigerian child to thrive. Every child that is at risk of an AS diagnosis, we want to be able to give those parents the help that they need. So see you tomorrow, like Nkoye has said. We are back here tomorrow by 5 p.m. We're going to be looking more at intervention and all of those things. So we hope to see you. Thank you very much for your time. Do have a blessed evening. Bye-bye.
Bye. Good night. Thank you.
Good night. See you
Yeah,
tomorrow.
bye-bye.
Bye. Hey, Adela, good to see you.
Good to see you too. But let me turn on my camera.
Thank you. Thank you, Miriam Afone, for staying. Thank you, Simi. Aminat Olatunju, thank you. Let me read. Thank you, Dare Dowu. Thank you, Tevitayo. Thank you, Agodi. Thank you, Jeremiah Oladeji Abimbola. Thank you, Duro Jaye Samson. Thank you, Tolani Ojuru. Thank you for staying up till now. Thank you. Kehinde Oloku, Aaron, thank you. Bola, thank you. UC Bax, thank you. Let's meet your friends tomorrow. Thank you, Bibola. Thank you. Oh, Android Blue Royd. I'm sorry, I don't know who that is. Thank you, Lola Ogunade. Shemu, thank you. Jimmy, thank you. Adashku, thank you. Ola Oshikotoyi, thank you. Joy Medupin, thank you. Yende Taibas, thank you.
Admin, I think we can close. Thank you very much, everybody, with your kind permission.
Thank you, Admin. I think.
All right. We should be able to extract the full report from the back end so that you can have all the charts and Q&A and all the results for your proper analysis.
Thank you very much. Thank you. Oh, and great job behind the scene, Admin. Thank you so much. Great job behind the scene. Thank you.
Yes.
So my audience is here. The next session is tomorrow. Today's one has ended. Please log out. Admin, please do your thing. Thank you.
Thank you very much.
You can end the meeting.